Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 382 of our pharmacotherapy series, which majors in pain and its management. My first question in the next case reads: PWJ is a 50-year-old man with a history of a right cerebellar ischemic stroke 4 years ago. He initially presented with sudden onset neck pain, nausea, vomiting, and dizziness. Since his stroke, he has had body tingling including all 4 extremities and his spine. He also has some localized throbbing pain in his neck and headaches. He reports some spontaneous jerking and muscle spasms that affect his extremities, mostly the right side, and sometimes down his back. He notes some right side weakness as well with muscle atrophy. He also describes chronic tinnitus, dizziness, and headache with sharp eye pain. His vision is normal per recent eye examination. He has chronic intermittent nystagmus, described as eye throbbing, when looking to the periphery on either side. He has headaches several times a week, which are frontotemporal and unilateral. Phono and photophobia are significant when they occur. He has nausea, but rarely emesis. He reports increased pain with cold weather and stress. He has a past medication history of hypertension, type 2 diabetes mellitus, and depression. He takes aspirin 325 mg by mouth daily, insulin glargine 72 units subcutaneously every morning, insulin lispro sliding scale subcutaneously 3 times daily, atorvastatin 20 mg by mouth every night at bedtime, and sertraline 200 mg by mouth once daily. He does not drink alcohol but is a former smoker who quit smoking 5 years ago. He used to work in a factory but had to quit because he fell several times at work. MRI of the neck showed only a mild disc bulge at C5 to C6. He was holding his head in his hands, wincing periodically. Otherwise his physical examination was unremarkable. He had reduced vibratory sensation in toes and feet to ankles. His neck was tender to palpation and he had some reduced range of motion. His gait was normal but slow, but reports being very unsteady on his feet. His vital signs today are as follows. His blood pressure is 126 systolic, 75 diastolic. He has a heart rate of 72 beats per minute. His respiratory rate is 16 breaths per minute. His weight is 149 kg. His pain rating is 9 out of 10. So my question to you reads: what symptoms does PWJ have that are consistent with central post-stroke pain, abbreviated as CPSP? Although PWJ does not have shoulder pain which may be present in central post-stroke pain, PWJ has some localized neck pain. He does not have any obvious injury, e.g., from a fall. Because he has not been very active, and he sits with his head in his hands or bowed forward, his neck pain is most likely myofascial. He has frequent headaches that he localizes to his frontotemporal area. Because PWJ's stroke was in his cerebellum, he has notable problems with balance and vertigo as well as tinnitus. These are not painful but are disturbing and limit his functionality and predispose him to falling, which may cause injury. He has intermittent nystagmus which he describes as throbbing. His vision and hearing were within normal limits, so his symptoms are sensory only. Since his stroke, PWJ has had body tingling affecting all 4 extremities. He reports some spontaneous jerking and muscle spasms that affect his extremities, mostly the right side, and right-sided weakness as well, with some muscle atrophy. And he reports that this is his most painful and bothersome symptom. However, on physical examination, there is not notable spasticity. He was noted to have decreased vibratory sensation in his feet and ankles bilaterally. The bilateral presentation is more consistent with his diabetes. He describes more pain with changes in the weather and stress, but this is not specific for central post-stroke pain. The next question reads, considering PWJ's comorbidities, what should be recommended for treating his pain? Treatment goals for PWJ and any stroke patient are 2. 1. Reduce discomfort and suffering. 2. Improve or regain as much function as possible. And 3. Improve coping. Because there is so little known about what causes central post-stroke pain, it is difficult to tailor analgesic therapy. PWJ has diabetes mellitus with symptoms suggestive of diabetic neuropathy. Amitriptyline is considered a first-line therapy for central post-stroke pain as well as diabetic neuropathy. Tricyclic antidepressants are also used for depression, though at a higher dose, and for headache prophylaxis. It is unknown whether the anticholinergic effects of the tricyclic antidepressant will affect his balance issues, because it may cause orthostatic hypotension. Of concern is his current use of a rather high dose of sertraline. Selective serotonin reuptake inhibitors do not offer any significant analgesia, and the selective serotonin reuptake inhibitor and tricyclic antidepressant combination will provide additive serotonergic effects, putting PWJ at risk for serotonin syndrome. A discussion with his mental healthcare provider is warranted to review potential analgesic options, including a trial of a serotonin and norepinephrine reuptake inhibitor such as duloxetine. Alternatively, the gabapentinoids may be helpful for his diabetic neuropathy, though there is less support for central post-stroke pain. Lamotrigine is likely a slightly more effective choice for central post-stroke pain, but lacks robust data for use in diabetic neuropathy. There do not appear to be any drug interactions or contraindications for either type of anticonvulsant. PWJ has some musculoskeletal neck pain and may benefit from a trial of acetaminophen or salicylates or a topical analgesic. However, non-steroidal anti-inflammatory drugs are contraindicated due to his history of stroke. He also has some intermittent muscle spasms that are quite bothersome for him. Typically, The antispasticity agents are useful, so he may benefit from a trial of tizanidine or baclofen. Non-pharmacologic therapies such as heat, massage, and physical therapy may be most effective. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 383.